Okay, then we will move on to the Spectra XT user panel discussion. So maybe we can invite Professor Kim, Dr. Hugh, and Dr. Peter Chen up for on the podium. Okay. And Dr. Jason Yip, sorry, you're not sitting at the table. I was looking out for you. Sorry. I was looking out, where was Dr. Yip? Okay, come. Okay. So chairing this panel discussion will be Dr. Hugh. Dr. Hugh Ying Kiat, I believe many local Malaysian doctors will be very familiar with him. So Dr. Hugh was a graduate from the Royal College of Surgeons in Ireland. He obtained his diploma in practical dermatology from the University of Wales. And he's definitely a very, very experienced aesthetic physician because he's many years in this business. And he was one of the founding members of the Malaysian Society of Aesthetic Medicine. May I hand over the mic to the chairperson for tonight, and he will introduce the two other speakers that will be providing the sharings tonight. Dr. Hugh?
Thank you, Gladys. Yeah, thank you, Lutronic, and congratulations on your 20th birthday. Just like Skin MD, I've also had a pretty long and very good experience with Lutronic Corporation. I think before it was even called Lutronic, it was called something else. Max Engineering was the name when we first got the laser. And I think you can see from today's talk so far in the pictures, and the studies have been published, right, that they make quite good lasers with many indications, and they continue with their research and development, and it's very good for the whole industry to get better and better results. And we also know that from the talks today that the current doctors actually use a lot of lasers in many different ways. So without further ado, let me also introduce my other panel from Malaysia. First is Dr. Jason Yip. He's actually working at the Astute Clinic now. He's the medical director of the FACE Incorporated Private Limited and Astute Clinic. He's one of the trainers also for Elegant Malaysia, my compatriot. He's also been using the Lutronic Spectra VRM3 since 2012 and the Spectra XT since 2014. And he averages about 1,000 Q-switch laser treatment procedures a year. Right, so, also is pretty well known. He's been around in the industry for quite a long time. And yeah, and I think a lot of us here know him. So, is there another? And I'm also supposed to introduce Dr. Peter Chen, and he's a dermatologist, right? I met him some time ago, maybe a few years ago, at some of the conferences. And he's a consultant dermatologist at Gleneagles in Kuala Lumpur. He obtained his specialty training from the Royal College of Physicians in London, obtained advanced masters in dermatology from National University of Malaysia, and previously was head of dermatology of the state of Pahang and Hospital Sungai Buloh. Okay. So, yeah. Sorry? Who first? Oh, okay, yeah. So I think a few of us are going to share a few cases just to stimulate some discussion. So, who wants? Yeah, I think maybe Dr. Jason Yip will start with his cases.
Thank you, Dr. Hugh, for the very nice introduction. Thank you to Lutronic and Skin MD for having me. It's an honor, and I actually feel very deeply humble, graced by so many prominent dermatologists and doctors, even Prof. Kim, Dr. Cho, Dr. Peter, and Dr. Hugh. So I think in terms of experience, I'm perhaps the doctor with the least experience here. Okay, so I'm just been invited to share a little bit about my case, my experience with using the Spectra XT. Can I have the... Okay. Sure, no problem. The Spectra XT is actually one of the machines that I immediately bought for my clinic. Like Dr. Siu, I just started my clinic about less than a year ago. So the Spectra XT has worked pretty wonders quite well for me in my previous practice. So when I got my new clinic, I actually got this machine. And on top of that, I also have the Qterra XLV. It's a long pulse 532 and 1046, which 1064, which I use a lot to treat my veins and melasma and whatnot. But today, I'm just going to be sharing purely on the Spectra XT, especially the extended platform. So what I love about this machine is because they have the 660 nanometer, which is great for things like lentigens and affiliates, like what Dr. Cho shared just now. Because of the spectrum, it actually has less oxyhemoglobin uptake, so there's less redness after the laser. So patient always recover faster, they have less chances of PIH. So you have this patient right in front of you. We just did one session of Ruby 660 nanometer. So just about 1 month later, you can see there's a quite significant clearance of the freckles or the affiliates. Okay, if you look closely, her overall texture has also improved, because usually I also do a bit of rejuvenation for her. So again, the 660, you can see the absorption spectrum, where you have much lower oxyhemoglobin, hence there's less chances for PIH. Okay. So I also use quite a fair bit of the gold toning. The gold toning is actually basically in the spectrum of 595 nanometer. It's like your pulse dye laser, the PDL. It's postulated that when you have acne and post-acne redness, you're actually targeting the microvasculature of the acne. So when you're using this 595, you're actually basically targeting this microvasculature, you're actually reducing this post-acne redness. And I've done about 3 to 4 sessions for this patient in very, very low setting, 0.25, about 3 to 4 passes, just a slight erythema. And subsequently, you can see from the photos, you can see the very, very pronounced reduction of the redness and acne, as well as textural improvement as well. Okay. So moving to the next case, again, sorry, back to the absorption spectrum. The 595, again, you have a very good absorption spectrum right at the oxyhemoglobin with a lower melanin uptake. Okay. So I have this patient of mine. She's actually went to some beauty salons. She did some chemical peeling, chemical dotting on her oil seeds. So she subsequently developed a bit of PIH all over the face. So she's come to me, and what I've done is I actually did a QPTP. QPTP is actually the photoacoustic twin pulse. Okay. So what it does is it has a much higher, much higher pulse, much higher, peak pulse, but much lower photothermal effect. So with about 7 to 8 sessions, we've managed to clear quite a fair bit of the PIH from the skin. So what you find is the QPDP is much gentler compared to your usual. Okay. Then, of course, I have your usual the melasma. In my practice, I usually combine a lot with the your long pulse 532 to treat the vascular portion of the melasma. But for this patient, I've only done the Q switch, and I use the subthermal laser toning. It's a much larger spot size, very, very low setting, just about 3 to 4 passes on the melasma. And usually you can get quite good clearance. Yeah. And with the normal 532 Q switch, you can always get very nice results even with your lentigens. Okay. So this is my final patient. She's been with me since 2012. So what I've done initially, I've actually used my Q switch to actually, this is horis nevus. So usually horis nevus, they are actually quite challenging to treat, particularly because you have to use a very, very powerful, very strong fluence. And in the end, you usually will end up with a lot of hypopigmentation, motopigmentation, and so on and so forth. So with her, we've managed to get very, very good clearance, especially on the cheekbones, even the under eye, and she actually has some on her nasal bridge as well. Okay, so we've got pretty good clearance for her, and now in 2017, she's still coming to me for a regular skin rejuvenation and toning, and she actually hasn't aged much from the laser. I mean, hasn't aged much subsequent from the treatment with the laser. So I've not done any Botox, I've not done any fillers, and I've not done any skin tightening device treatment for her. So this is her just on the Q switch, and she's been doing regularly since 2012 with me. Okay, thank you.
Okay, thank you, Dr. Jason Yip. Yeah, very interesting cases. So, any questions from the audience? Okay, if not, then I think let's proceed. Maybe next will be Dr. Peter Chen.
During the cases, we can continue to discuss and ask questions. I think with the settings will be nice. Yeah, thank you. Yeah.
I think
you
I'll
prefer to stand. Okay.
And it's a bit too serious, Gladys. Where is the dance floor, whatever?
So questions are welcome even during the talk. I mean, anyone, you can raise your hands. You don't have to interrupt.
Yeah, so if
verbally.
You see, yeah, if you
Raise
see
your
a
hand so
similar
that-
case or two that to the cases that you are doing differently and you like to ask, then the panels, then please raise your hand. We'll bring the mic over to you.
Yeah. Okay. Thank you. Okay. Gladys just informed me. I mean, Rachel just informed me a few days ago while I was in Switzerland for the EADV that I'll be presenting. So I tried to dig out these 1 to 2 months cases that I had, Okay, so here are the cases. Okay, athletes or freckles. This patient, we use a 660 nanometer, as they call it, RUVI, Q-switch NDE. Don't try to remember the settings. To me, when you do lasers, it's just like roasting a chicken that you just ate. If you prefer a bit charred, you want to roast it until that level. If you prefer a bit raw, you roast it until that rawness, So the main important thing to me is the end point. What is the end point that we are trying to achieve in this case, freckles? It's just a slight mild whitening, or people call frosting. So in this case, I use a 2 millimeter, 1.6 joule per centimeter square. But importantly, you need to know how many frequencies. The frequency is freckles is definitely 1, and you just need 1 pass. So after 1 session, this is the results. From the side. And what about this lady? This Caucasian lady came to me 2-3 days ago with pigmented macules over her tip of the nose. Should we laser it or not? If you look at it, there's some difference in the pigmentation, right? A bit darkened over here. So, but on dermatoscope, it is perfect lentigens. It's just a lentigens. Nothing to be afraid of. We would just laser it. But what about this case? This Caucasian lady came to me with this almost similar macule as well. But when you look at the dermatoscope, it's actually, there is budding there, pseudo budding, and you see the asymmetrical in the color, and you see this blue veil. So this is malignant melanoma. If I were to laser it, you'll probably come back with this, malignant melanoma, right? But nowadays we rarely see this kind of case. This lady from poor makcik from some kampung that came to me with this late stage of malignant melanoma. So for lentigens, it's quite straightforward. We also use this. I prefer to use the 660 nanometer as well. 3 millimeter, 0.9 joule per centimeter square. Same as the freckles, 1 Hz, 1 pass, and just 1 session, you can get these results. So even on the upper limbs. But for lower limbs, I'll be a bit more careful because the risk of post-inflammatory hyperpigmentation is higher. Right? Now, nevus of Otta. We know it's a dermal lesion, so you need to use 1064 Q-switch NDE, and spot size that I use 4 millimeter. This is after 2 sessions. Yeah, the nevus of Otta is here. After 2 sessions, it gets lighter. And for nevus of Otta, we need a higher frequency, 5 Hz, 1 pass. This is during her 3rd session, which is also about two days ago. And normally, nevus of Orta, we were told to hit until a bit of pinpoint bleeding. But in this case, you see some erythema there, just some erythema. Do we stop here or do we continue to increase the energy? If you look at the dermatoscope again, you can already see the pinpoint bleeding there. But more importantly, I think to answer Dr. Ting's question just now also, I think nevus of Orta, if we overheat, we tend to get this hypopigmentation, which we can't see clinically. But if you look at the dermatoscope, you can appreciate the hypopigmentation. And if you were to increase the energy further, then you will cause more hypopigmentation. And this is tattoo removal, QC Chandelier. This gentleman has really gone to a few centers, had multiple sessions of lasers, and he came to me and he's particularly concerned about the red tattoo. So red tattoo, we know you can easily remove it with just 532. And just with one pass, and endpoint. Again, the endpoint is this mild frosting, right? And with just 532, 2.4 millimeter, 2.4 joule per centimeter square, 1 Hz. You can go 2 Hz if you feel it's too slow, 1 pass. And for the black tattoo, we use the 1064, 4 millimeter, 4 joule per centimeter square, 1 Hz, and 1 pass. Yeah. Melasma, I use a 1064 QPTP. Yeah? It's more gentle, the QPTP, and I use 10 millimeters spot size, 1.3 joule per centimeter square. As I said, look for the endpoint. The endpoint here is mild erythema. So I can increase 1.3, 1.4, 1.5 until I get the erythema. So I use 5 Hz because my right hand is not that fast. I know some of you can go very fast with a 10 Hz, but I prefer to go slow and steady with just 5 Hz. 3 passes, and this is just after 1 session, plus sunblock, without any whitening agents. Yeah. Okay. If you notice that for her, there's also some vessels that disappear. This is because we did a long pulse 1064 for her as well, not because of the Q switch here. Finally, for melasma, I always advise my patient on UV protection. Otherwise, it's going to come back again. So this lady who came with very bad melasma, and after I treated with the 1064 QPTP, she was very happy with it. The melasma almost cleared. And after talking to her about wearing masks, wearing tudung, the one with the awning, and big sunglasses and everything, she actually sewed her own mask. And she took one of Chanel bag, and then she sewed it at the top here. It's actually Chanel is written inside there. And she has been with me for many years. And she is one of my favorite patients because her melasma rarely flared up. Even if it flared up, it's just very minimal, and just with one more round of 1064, it's cleared. So take-home message is you still need UV protection despite how good the lasers are for melasma, right? And the best protection is still physical block, all these shields, rather than sunblock. Yeah, with that, I thank you.
Okay, thank you, Peter, for the very nice pictures also. So I think so far we all had very nice pictures. And same with Peter. I was told way beforehand that I was going to be a moderator or chairperson for this panel discussion, but I didn't know that I had to present my own cases as well. So I think that also led to a bit of a last-minute, arrangement, so that I could present something. So it was only again in the past week or so that I gathered cases. But my approach was a bit different from Peter's. I dug up old cases. So here I'm going to present some of the cases. For me, I think, for me, I actually don't have the Spectra XT laser. I have the older version, which is the VRM. I've got both the VRM3 and the VRM Spectra, right? So These lasers have been my workhorse, and I've been doing the same kind of things as you will see afterwards in the pictures. And I think they can still give very good and beautiful results, even without the newer technologies. Again, one of the reasons why I invested and bought into the laser that long time ago, maybe about more than 10 years ago, was that when I surveyed around, I couldn't afford the very expensive branded lasers from America, all these Candelas and Met lights and all that. So I was looking around for the next best thing. And I think from Korea, that time, the most stable platform at that time was actually Lutronic or Max Engineering. So that's why I chose the laser. And as you can see, it served me pretty well. I'll show you some pictures now. Okay, so this is Horis nevus, right? Explained before, quite well, I wouldn't say common to see, but we see it on and off. And this is actually quite an interesting case. This is actually a lady, a girl, who was actually from hairdressers next to my clinic. And she presented like that. I mean, a lot of times when you see Horis, it may not be as florid, as pronounced as this. Is actually quite pronounced. So she came to see me, and of course, I gave the usual. Those are my settings at 4 millimeters. And, session after session, it kept improving. Of course, initially, it can be a bit slow. So I think those of you who want to attempt to treat Horis, you need to be patient as well, together with the patient. Because if you try and rush, if you try and hit it too hard, you might get PIH, you get all kind of confounding complications. But if you do it very slowly, and you are patient, and you explain to the patient that they need to come back multiple times, you can get very nice clearance like this. Interesting case I mentioned in this particular one is because after she got very nice clearance, she brought in a lot of friends with the same problem. And they all happened to be working in the same hairdressers next to my clinic. So this is a very interesting one. I don't know what caused it. Could it be the environment? Could it be the chemicals they use, in the hairdressers? Because these are actually not the hairdressers themselves. These are the girls who wash the hair for the clients. So maybe something that can be studied. But like I say, very nice clearance. And until now, she's still very happy with the result.
Dr. Hugh, may I ask how often did you treat for the last 8 times? What were the intervals?
Intervals, I just followed the standard, which is about 6 weeks. Yeah, so time enough for the macrophages to clear away the broken bits, of the pigmentation. And yeah, like I say, initially it may be slow going. You might not see any response, even after 1, 2, 3, sometimes even 5 sessions. And then suddenly, it clears up. You just have to be a bit confident in your own abilities and also the laser's abilities. Okay, we see a lot of... is there a question? Okay. Okay, initially, again, I think in the past when the pulse durations were actually a little bit longer, right, even in nanosecond mode, I think I was taught early on to actually do until you see PTK, right? But as the years went by, I tried doing it without PTK, just a bit of redness, a mild erythema with no breakage of the skin at all. Again, you have to trust yourself and trust the laser. And yeah, that's my endpoint now, no PTK. Well, I'll be hitting around, so I won't call it a single pass.
We see a lot of Horis nevus in Singapore, Malaysia generally. So maybe we can open a panel and see if any of the panelists would treat the Horis settings differently. I'm not sure, but we would love to hear from the panel what kind of settings would you have done if you had seen a case like this? Would there be a different setting?
I also hit until just erythema. You see a bit of swelling erythema there, but just one pass because we're using 5 Hz already. Yeah.
Yes. Oh, Dr. Jason, do you have any experience with Horis?
Hello. Likewise, I usually just look for a slight redness and a slight swelling, and that's it.
What about the Korean's Horis? Is it different?
Okay. In my cases, when the Horis nevus patient come to my clinic, I check another pigmentation. If the patient didn't have another pigmentation, such as lentigen or any other photoaging signs, I choose very high energy. And in my case, I like a 3 months interval because many publications show that, especially nevus aorta thermal pigmentation, the optimal interval was 3 months, and so I recommend the 3 months intervals. And if the patient combined with other pigmentation such as melasma or lentigens, I choose relatively lower some energies because the high energy treatment sometimes aggravated post-inflammatory hyperpigmentation. Yeah.
In our clinic, we also treat the patients with Horace nevus at 2 weeks intervals or 4 weeks intervals, but lower the flu ones than previous time. So we don't have to make on PTK, just erythema or mild PTK, and we can wait for over 2 weeks or even 4 weeks or longer. So we can wait.
Thank you.
So there's tremendous variation in the intervals, huh?
Yeah.
As you can see.
Interesting.
So I think you
Yeah.
all have to decide for yourselves.
But I agree that we need to give it time.
Yeah.
Because we know the main thing is to wait for the macrophages to come and eat up the pigment, you know.
Exactly.
So no point doing it 2 weeks, every 2 weeks or whatever.
Okay.
So, Prof. Kim, you actually use a much higher fluence and a longer interval.
As in a case of without any other pigmentary problems, only Horace nevus, I regarded it as like nevus of others in child patient, and so high fronts, the endpoint petechials, and waiting during the 3 months, and all of destroyed melanocyte observed human bodies as macrophage functions, and it takes the optimal, it takes at least 3 months, yes.
Okay.
Thank you.
Next case. Then, well, this is very pretty standard, stock standard freckles, right, or athletes. 532 nanometers. The new settings for the lasers are at 1.7 millimeters for the 532 KTP instead of 2 millimeters, adjusted for the focus of the spot size. Yeah, pretty standard. So I think we can skip this one, right? Another one, also very similar. Yeah, same, one treatment. Usually for those that you see are totally epidermal pigmentation, you can get very nice clearance. Again, with the lasers, the main thing you need to worry about is that the endpoint is not too strong. You don't want to overdo it. PIH is very common among Asians, so you want to avoid it. You want the smaller spot size you use, the more accurate it is. And but the problem with some lasers is that you put very small spot size, like 2 millimeters and below, the energies tend to go up a bit higher. So you need to find a laser with a very stable power that can give you a small spot size, and one way you can actually tune down the power a little bit to less, so that you don't overstimulate the area. So again, very nice clearance for freckles. Then this is a patient I have. So this is a girl with a dragon tattoo. Those who
Wow,
read
nice
the book.
result.
I haven't
Yeah.
actually. But this is a girl with a dragon tattoo. And got pretty good clearance. Actually, I did for her maybe about like 5 sessions, right? Again, my interval is same, is actually once every 6 weeks. Initially it was once a month, then eventually I said, you know, you have to give it a little bit more time. So she did 5 sessions, it was kind of still present, faded quite a bit. Then I lost her for a period of time, for about a year or 2, I don't know what happened to her. Then when she came back later, you know, you're still a bit faint, so I gave it another a few more sessions, and actually I managed to get quite good clearance for this tattoo, this dragon tattoo. So I think with pico laser, probably I can get it all off. It's quite nice in the sense that I don't see any hypopigmentation, not too much. And for me, you can see some slight erythema because in this picture, she actually had the numbing cream applied onto the skin, and then just before I did the laser, I took the picture, right, just to try and get a little bit off. Since I haven't heard from her, so I think it must have been quite satisfactory for her. And this one was one where the patient has dark skin, right, Indian type skin, and she only wanted part of the tattoo removed because, you know, she broke up with her boyfriend. So part of it has to go. Anyway, that's after just a few treatments, and in this case you can see a little bit of tattoo left and a bit of erythema, but she was happy with enough for it. And the reason why she had to remove that was because she was going to get married to another person. This is one of my biggest challenges. It's tattoo, but there's no before and after because you can actually compare one side to the other. Both were about the same kind of color, and we got quite good results. He also sort of stopped after this because it was very long drawn. It's very painful when you do such a big area at a go. So it's like the guy in Prison Break, except this one is also very colorful. And yeah, so again, this I think shows that the Spectra machines are actually very good. Again, I'm actually pretty conservative, so I think I managed to sidestep the problem of getting hypopigmentation or mild sort of raised area of skin at the treatment area.
So Hugh, did you use the colored areas, right? I see
Yep.
quite good clearance. Did you use a different energy?
I used about that.
Across board was,
Yeah, but when it got lighter, I raised up the energy a little bit more.
I
Yeah.
see.
We know that here we know that green tattoo is not it does not respond to 1064. So did you do anything else besides just 1064?
It was actually just 1064. So it may be because a very good photoacoustic effect just happened. It was a pretty fresh tattoo when I first saw it. So maybe I got it at the right time. And yeah, so that is, the picture speaks for itself. Again, like I said, I don't see this often. I don't see good clearance for green tattoos all the time, or yellow tattoos for that matter, or blue tattoos. But in this case, it seemed to have worked quite well, which is why I'm showing the results. And then last but not least, yeah, melasma. Normally, my first line would not be to do any lasers. I usually use creams. Those of you who know me over the years would know that actually I don't really like toning, but sometimes I do toning. And in these cases, usually I don't do it very regularly. As and when the patient comes in, and it worked quite well for her. Together, this is actually combination with topical lightening agents, hydroquinone 4%. Yep. And thank you.
Maybe we open to the floor some questions. Some of you might have prepared some questions to come. Sandy?
Hello, good evening. I'm Dr. Tan from the Philippines. I'd like to ask a question to the panel. For those who use the 660, my first question is, when you use the 660 for pigmentation, do you shoot the entire pigment with a 660 or do you leave normal space in between each spot?
Okay, for me, each pigmented area I will shoot.
So you shoot 100%?
100%.
Okay, and a follow-on question. Even if you use a 3mm spot size, sometimes if the pigment is kind of light, you notice the spot is even smaller, sometimes 1 or 1.5 millimeter instead. In that case, do you still shoot 100% or do you leave some space in between?
I use the 2mm spot size then.
Okay.
There's a 2mm spot size.
All right. Yeah, okay, thank you.
When I use 3mm, I can also see the 1mm whitening or 2mm whitening, and I add also the between the space between the 1 or 2mm spot 660 frosting.
So
I
you
add
prefer
more.
to shoot everything?
Yes.
All right.
The 100.
Well, about any questions on 532? Because we tend to hear a lot of calls regarding 532, actually. So, is there anyone would like to ask, or maybe Doctor, since XT had 660, I realized that of course most of our doctors start to convert to 660, but when it doesn't really respond or it comes back again 7 months, 8 months down the road, should the doctor choose to use 532?
I think the reason why it comes back, as we know that it's almost impossible to avoid ultraviolet. It will come back. no matter what, melasma, your freckles, your lentigens, you know. So since it responded well to 660, I will continue with 660. It's not because it is resistant to 660. Then I'll probably think of other ways to do it, you know, even using a very mild setting of CO2 to remove it, or even just chemical peel or whatever. Yeah.
Okay, yep. Because this is a very common question we get, because a lot of doctors actually say, oh, it keeps coming back twice after 660. Should I change to 532? So
Because when we use 532, we found it a little bit blurring of the margin of
Yes.
the treated area. But when you use 660, we can see the clear margins of the irradiated area. But this kind of razor-induced frosting, we can see when we use the Pico Plus 532. So when I fail to treat the whole of the lesions with 660 nano, we then change into the 532 Pico. Then we can get a satisfactory effect. But when we see then no response to 532 Pico, we can then nano 660. That would be sometimes effective. So.
Yes,
sorry.
Sorry, again, I don't have the Spectra XT, so I don't even have the 660. I don't have a Pico, so I'm still using the traditional 532 nano. For me, because I am limited to that laser, for me, it's quite simple. I just tell my patients, if it doesn't go off the first time, it's not epidermal anymore. It's a bit deeper. And then we try other strategies, like you say, chemical peels, or use medical lighteners for a while to see if it fades off. Yeah.
Sometimes less MD also effective for managing that.
It's interesting you said the 532 Pico on Pico Plus. Do you see a different endpoint on Pico Plus 532 versus the Spectra XT 532?
Because I have some limitation in my experience with Pico Plus, but when I use Pico Plus 532 with a mild change of just pigment or just minimal to no erythema on the pigment does not result in a satisfactory effect. But when I use the Pico Plus 532, I would like to make a very light frosting on the skin. That is similar to the effect, the results of the 660 or 532. So the end point is pretty much similar.
Thank you. Okay.
Hello, hi, I'm Dr. David from Singapore. I'd like to ask the panel on your experience with XT's PDP mode on melasma treatment. So what's your typical setting? And number two, have you all ever experienced motor hypopigmentation with the PDP setting, and what was your fluence then, the interval then?
Okay, QPTP is supposed to be used for to reduce the pain and for dry skin, right? But for me, since I have it, I use it for all my melasma patients, all the BIH, the 1064 setting. The endpoint, as I said, the setting, no point. If I tell you 1.1, 1.3 joule per centimeter square, you know, at the end of the day, look for the endpoint, which is just mild erythema. Because your machine may be new, my machine may be old. I may need a higher energy. You know, when I first got the Spectra XT, how I wish that the energy can be even lower. Because when I first used the 660, 2 millimeter, I reduced down to the minimum affluence, and I already got a very thick frosting already. You know, I can't lower it further down. Then as time goes, it gets lighter and lighter and lighter. So that's why I don't follow the setting, whatever included inside. But it's good to refer to the manual so that you have a baseline. At least you start off from there and then you increase further. Don't go the hero way of starting from high and then go down that way. You know? Did I answer your question? Yeah. Oh yeah, hypopigmentation. So far, no. You know, for me, in my case, if you talk about melasma and PIH, if you talk about all this dermal lesion, like Horace nevus just now when I show you, I get surprisingly with dermatoscope, then only I can see the hypopigmentation. So nowadays, whenever I do any dermal lesion, I will bring out my dermatoscope and look at it. After one shot, I look at it. It's not there. No pinpoint bleeding. I increase the fluence again, and further on. You know?
From my personal experience, I used to do a lot of laser toning. And if you read the study by Dr. Henry Chan, and he published a study that says that even with a very low level subdermal toning, you still, there's a possibility of getting this punctate leukoderma. So once I've developed some of these cases, I've actually converted to QPDP. I find it a bit better, but it's just that it's very difficult to get the photothermal effect for rejuvenation. So, but it's effective in breaking down the pigmentation, but not so much for rejuvenation.
I start from PTP 7 millimeters per size and 1.6, and then according to the patient's response, I can reduce the fluence or increase the fluence. But when I use the PTP mode, even PTP mode, but more than 2.0 joules per centimeter scale, resulting in a mild hypopigmentation. But in that case, that was not permanent. That was just a transient, irregular pigmentation, but that was transient. So in cases of melasma, I start from PTP 1.6, but in patients with acne-prone patients or sensitive skin with post-toning pustules on the face, I rather choose not PTP, but a conventional single pulse mode for them, 1.2 joules per centimeter scale or lower.
I think I can also stress again that if you're dealing with a case like melasma, it's always evolving and changing. So it's not curing it anyway. If you whether you use PTP or normal toning, and it can come back again. So just go gentle with it, and you can expect sometime at some stage the patient might come back because of sun exposure, because of hormonal changes over time, or something has aggravated the melasma.
We also have to bear in mind the setting from the Korean and Malaysian, because our skin type, mainly type 3, type 4, type 5, but theirs is mainly type 3, type 2. So I think for me, I don't start straight away with 1.6 because of our skin color, So we will start lower, than that,
Oh, one more question.
Yeah, sorry. Can I go back to about this treatment of Horis and this, as well as nevus of aorta? I've been doing this treatment for quite a long time. I've tried different kinds of endpoints. I've tried just a bit of redness. I've tried PTK, and actually tried even frank bleeding. And from my personal experience, the patients actually get bleeding, gets the best result. Actually, some patients of mine will tell me, oh, that last session, it didn't work well. The session before that, there was some bleeding and it worked better. So can I have kind of some other comments as to which is the best setting, or rather the best endpoint?
To share with you, if you to look at my slides, you will notice for my Horis patient, I actually use much higher fluence compared to the other doctors. My fluence was up to 7 to 8 joules, and there was some frank bleeding in a few cases. And I agree, clearance was much better as opposed to later on when as I go along, I got a little bit more conservative. I see more complications, I agree the frank bleeding got better results compared to my other patients, which I was a bit more conservative. But on top of that, I noticed that sometimes to prevent all this PIH and all that, I always recommend that the patients use a lot of moisturizers. I find that when the skin is a bit too dry, they usually always somehow develop some form of PIH and so on and so forth. So even with frank bleeding, with a good post-laser care, they usually do quite well after that.
I think I'll just still go back to the evidence. But because so far I haven't come across any literature that says go until frank bleeding. So I would not dare to go until frank bleeding. Although you never know, it may have better results, but we may have complications as well, scarring later on. So I will not dare to try that frank bleeding. So my endpoint is still pinpoint bleeding.
For me, it's also what the patient wants. For me, because the patient usually doesn't, you do frank bleeding or even PTK, there's going to be mild scabbing, crusting, right, for the next few days. So my patients don't like the downtime, and I find that I may end up doing more sessions, right, with the lower fluences, but the patient is actually much happier. I say, redness will clear, once the heat goes off, right, within a day or two, so there isn't even any downtime to speak of when you don't have any PTK. Sometimes, when I maybe a bit overzealous, do a few more shots, I get tiny petechiae, and then I stop. Yeah.
But for all this, I always tell my patient, we need many sessions. It's not like freckles, I can clear it within 1 to 2 sessions. So there's no hurry in clearing the thing. I already preempt them that it's going to be 7 sessions, 10 sessions, then only we can see the improvement.
Pico laser.
When we use the prior version of Spectra VRM or even Spectra K, we can see the bleeding or the severe PTK after the same parameters compared to the Spectra XT. But when we started to using Spectra XT, we cannot see the endpoint of bleeding or severe PTK, just mild PTK or some kind of similar endpoints. So after changing their PIM profile compared to the VRM3 or other version, the endpoint has been, in my opinion, endpoint has been changed depending on the PIM profile. So in our clinic, although I want to make a bleeding endpoint to the patients who can come over our clinic just 1 or 2 times per year, but I cannot do them, provide to them the bleeding endpoint of treatment, just providing them a high fluence, but no bleeding, but the PTK only. But waiting for more months, we can see the satisfactory clinical response.
Can I ask Dr. Cho, you use thallium for hair growth. What is the mechanism of action of this thallium? How does it make the hair grow?
Hair growth. At first, I had been using the mosaic for the hair treatment for about more than 5 years ago. But after that, by we believed that heat stimulation can result in an wound repair process, and wound repair process can gathering some cells or some growth factor release by our scalp skin and result in a regrowth of the hair. But at that time, we experienced that after repeating the treatment, we can see mild scarring change of the scalp. So we stopped that treatment and we returned to the mesogun therapy on the scalp and the injection therapy. But our main purpose is just we no more use mesogun because it is not promising and it is not a predictable result. So we would like to just change mesogun into something like an energy delivery system. But after using that energy delivering system of LaserMD, we experienced that is more promising than mesogun or mosaic. So from that time point, we think about the mechanism. So our mechanism is also similar to the mosaic, but that as I told you before, that stimulate the scalp skin, and after making a tiny but non-excessive thermal wound on there, during the wound repair process, they can release, we believe that they can release the growth factors or some kind of the components that are good for the hair growth. And the other thing is when we just inject a tissue activator like a polydeoxyribonucleotide on the scalp, that results in good response, but not satisfactory sometimes. But after adding LaserMD and the PDRN injection, we might think that the waste of injected PDRN is much lower by adding the thulium laser, because that wound making requires much more the PDRN or some kind of tissue activators for their recovery. So we believe that by synergistic effect of laser-induced growth factor release or and PDRN injection also results in a growth factor regrowth of the hair. And one more thing is by using the mosaic laser, Dr. Wonseok Kim, Professor Wonseok Kim previously reported that the mosaic laser can induce the early stages of follicular genesis. So we believe that we have a limitation that mosaic laser we cannot do every week for over 6 months, but by using thulium laser we can do more months. So we can safely deliver the laser energy to the scalp skin and induce the growth factor release, and we can fully inject the tissue activated on the scalp. That is my opinion.
Thank you.
How fast you can deliver the solution after the laser? You know, from the time the laser penetrates into the skin to the delivery of the solution, how fast is it?
How fast? Actually, in my clinic, we cleanse the scalp skin with the mild soap and cleanse with the 70% alcohol and deliver the LaserMD first, and then immediately after inject onto that with the PDRN or some kind of placenta extract available in Korea. And then we apply CK ampoule onto that. But within 10 or 20 minutes, that I think that is not the late time. But because our slide presents that even in 1 hour or all the areas were healed up within 7 days, but within 1 day, we believe that still the channel, the small micro channel and even big channel is remained on the scalp. But when we use 5 watt, 20 millijoule, we can cut the hairs, the shaped hairs. So we should lower the energy setting and repetitive delivery of that machine on the scalp. And 1 week after the treatment, we can even see the small spots in the scalp. We believe that there is a channel, but that is might be different pattern when we use that on the face. Healed up fast, but on the scalp skin remains for a longer time. We believe that.
Okay.
Just one more question. I know we're a little bit over, but one last question. For those using the 595, do you find it necessary to use it after every 1064 treatment for melasma? And if so, how high in energy do you recommend?
I'm sorry, but I must leave here because I have the flight back to Korea. And,
Okay,
sorry.
great. Maybe we have a chairperson to hand over Professor Kim a token of appreciation and thank him for spending his precious time with us. Thank you, Prof. Kim.
We believe that adding on 595 nanometer is not necessary for treating melasma. That is similar with this yellow or XLV like that, because when we have encountered with the patients with refractory to the conventional laser toning treatment, we can add more. But in cases of some hyperpigmentation in combination with the contact hyperpigmentation or easily redness or underlying vascular components, we can add 595 in the case, but not all the patients, I think, need an additional 595 for the treatment of melasma.
Okay, I think we really maximized our time. We were supposed to end at 8 o'clock. So I'd like to thank the panel here. Hang on, we have a little token of appreciation. But in the meantime, doctors, please don't go away. We're going to have a quick group photo after we give out the tokens of appreciation. And then we have a dessert buffet outside. And you can party till very late if you wanted to. Okay, so we can have drinks and we can have dessert outside. So hang on there and just give us a minute, and we'd like to ask Dr. Hugh to thank the panel for their good sharings. I hope everybody has benefited from the session.
Yeah, thank you, Gladys. Thank you, Lutronic, for tonight's dinner and talk. And thank you, my esteemed panel. Of very respected doctors who are using lasers.